Welcome to the Deep Dive. Today, we're tackling a really fundamental question. How do we actually know if the healthcare we get is any good and safe?
Yeah, basically, what makes for quality healthcare?
Think of this as your quick guide, sort of, to understanding the whole landscape of quality in healthcare.
And in this deep dive, we're going to explore exactly that. We've pulled together insights from, well, all over the place, international organizations setting the bar,
Right.
national bodies making sure standards are met, practical tools for actually making things better on the ground.
And the everyday guidelines that, keep things running smoothly.
Exactly.
So, yeah, we're looking at the work of Joint Commission International. They're a major force globally, and also findings from an NCBI article that digs into clinical practice guidelines.
We've also got info from India's National Accreditation Board for Hospitals and Healthcare Providers, NABH.
Right, NABH. Plus some real-world perspectives from healthcare consultants and resources on how you actually do quality improvement.
So the mission today.
Our goal, really, is to give you a clear picture, the whole spectrum of healthcare quality, from those big international benchmarks.
Right down to the practical steps, the stuff that leads to better patient care.
Okay, let's unpack this. Maybe start with those global standards, JCI.
Let's do it. So Joint Commission International, or JCI, they've been around for, over 20 years?
Yeah, quite a while.
And they've been a leading voice, really pushing for higher quality and, crucially, safer healthcare across the globe.
Their core idea is pretty straightforward, isn't it?
It is. It's basically that everyone, everywhere, should expect and get the safest, highest quality care possible, simple but powerful.
So you could think of JCI as kind of the gold standard then.
You definitely could. Hospitals that get their accreditation often show, real improvements. Lower rates of infections acquired in the hospital, fewer medication errors.
Things that directly mean safer care for patients.
Exactly.
And JCI doesn't just, help hospitals do well. They have a process, right?
Oh, yeah, a really rigorous accreditation process. It's built on these demanding international standards, covers both quality and patient safety.
So if a hospital or clinic has JCI accreditation, that's a pretty strong signal.
It's a very strong signal. It means they've really committed to meeting some significant benchmarks. They've been evaluated against them.
And these standards, they're not just for the evaluation, are they?
No, not at all. They provide the whole framework. It's how JCI assesses performance, sure, but more importantly, it's how those organizations can then measure themselves, evaluate what they're doing, and crucially, continuously improve.
Right. So for you listening, if you want to quickly grasp what the established benchmarks are.
JCI accreditation is definitely a key indicator to look for.
Okay. So that's the global view. Let's narrow the focus a bit. Clinical practice guidelines, our NCBI source looked into these. What did it find?
Well, what's really interesting here is how guidelines are adapting. The source talks about the challenge, the very real need for fast responses, especially during, say, an epidemic.
Like we've seen recently.
Exactly. And this has pushed the development of what they're calling rapid guidelines and even living guidelines.
Living guidelines. That sounds dynamic.
It really is. The idea behind living guidelines is revolutionary, trying to close that gap, sometimes years long, between new research coming out and it actually being used at the bedside.
Which could potentially save lives much faster in a crisis.
That's the hope. These approaches look at using real-world data, large collections of patient information, registries, that sort of thing, to update recommendations much quicker than the old ways.
Okay, that makes a lot of sense when information is changing constantly. But is that real-world data always the best foundation for deciding on treatments?
That's the million-dollar question, isn't it? And the source touches on this. While that observational data is incredibly useful for showing us what's happening now, how care is delivered, where the gaps are, spotting safety issues, it's generally not the first choice for saying, definitively, this treatment works better than that one. The NICE guidance review mentioned actually found using this data in guidelines has been, maybe a bit slower than people hoped.
Interesting. So it's more for understanding the situation than dictating treatment in every case.
Yeah.
Got it. Now, another tricky area with guidelines, conflicts of interest.
Oh, absolutely. The NCBI source really flags this. It stresses how important it is to be transparent about conflicts and, crucially, to manage them.
How do they suggest doing that?
It points to principles from the Guidelines International Network, or GIN, and there's even a German website mentioned, leitlinienwatch.de, literally Guideline Watch, which actually evaluates how well German guidelines are handling potential financial conflicts.
But it's not just about money, is it? Like direct payments.
Not at all. That's a key point. You have to manage the direct financial conflicts, yes, funding from a drug company, for instance, but also the indirect ones,
Indirect line.
like wanting career advancement or how a recommendation might affect a doctor's own income or their reputation or even just a deeply held belief about a certain treatment.
Yeah.
Lots of subtle stuff.
Wow, yeah. That's a lot to consider. So how do they try and keep that in check?
Well, the article suggests that using multidisciplinary panels is key. Bringing together experts from different fields, different perspectives.
Makes sense. Dilutes individual bias.
Exactly. And also using really robust processes for reaching consensus. Getting a diverse group to agree, it helps counterbalance those individual influences.
Right. Okay. Thinking about actually using these guidelines, is there like one central place to find them all? For doctors or even for us?
You'd think so, wouldn't you? But surprisingly, at least at the EU level, the article says no. Not like there is for, say, health technology assessment, which is more centralized. And what's really noteworthy, a major guideline clearinghouse in the U.S., one that many people internationally used, was recently suspended.
Really? Wow.
Yeah. So it raises a big question, maybe for you to ponder. Should there be a more centralized system for accessing guidelines? It certainly adds a layer of complexity right now.
Definitely something to think about. Okay, let's pivot a bit. Let's talk about NABH, the National Accreditation Board for Hospitals and Healthcare Providers in India.
Yes, NABH, it's a great example of a national accreditation body really focusing on pushing up quality, safety, and even wellness within Indian healthcare.
And they have new standards coming out.
They do. The source mentions the 6th edition is due in January 2025, and their aim is pretty bold to really inspire a new era of excellence.
Sounds ambitious. How do they structure these standards?
It's quite neat, actually. 10 chapters, they divide them into 2 groups. The first 5 are patient-centric.
Okay, focusing on the patient journey.
Exactly. Things like access, assessment, and continuity of care, care of patients itself, management of medication, patient rights and education, and infection prevention and control.
Makes sense. And the other 5?
Those are organization-centric, looking at the systems behind the scenes.
Sorry.
Patient safety and quality improvement, so the QI stuff. Facility management and safety building equipment, human resource management staffing, information management systems, records, data, and governance and leadership.
So it really covers the whole operation, connecting the back office to the bedside.
Precisely.
Right.
It shows how the patient experience relies on that whole organizational infrastructure.
The outline mentions something called controlled documents. What are those?
Yes. Controlled documents. Think of them as the official rule book or manuals for the hospital. They're essential for consistency.
Like standard operating procedures, SOPs.
Exactly. SOPs are a key type. Policy manuals, too. They lay out the authorized way to do things step by step. And the controlled part is crucial. Any changes have to be formally approved and tracked.
So everyone's working from the same up-to-date playbook. Stops people just doing their own thing.
That's the idea. Consistency and accountability.
What kind of details are in these documents?
Usually the document's name, its purpose, when a process starts and stops, the actual steps involved, any related forms or other documents, and, importantly, who signed off on it and when it became active.
Got it. So getting NABH accreditation isn't just a one-off then. You have to maintain it.
Oh, absolutely not. It requires ongoing work. Hospitals need to keep up a high level of compliance. The target mentioned is at least 80% overall during follow-up checks.
80% overall.
Yeah, but it's not just the total score. There are specific requirements for certain elements, too. And if a score drops below a certain point in any area, the hospital has to create and follow an action plan to fix it.
So it keeps the pressure on for continuous improvement.
Yeah.
Were there any notable changes between the old NABH standards and this new 6th edition?
Yes, definitely some tweaks reflecting current thinking. For example, the chapter on access and assessment now specifically calls out defining the scope of services offered and addressing preventive care. In medication management, there's a shift from talking about excellence to focusing on commitment, maybe ensuring the basics are solid everywhere. They added rules for vaccine storage, removed a requirement for certain audits.
Small but potentially significant changes.
Right. Even in facility management, there's more emphasis on actually implementing safety plans, not just having them on paper. And interestingly, standard treatment guidelines, STGs, are now officially listed in the abbreviations.
Showing their growing importance.
Seems like it.
It sounds like they're constantly refining things.
Yeah.
You also mentioned NABH focuses on patient assessment and care planning.
Yes, that's absolutely central. The standards stress doing thorough initial assessments, but also ongoing assessments to see how the patient is doing and adjust the plan.
So it's dynamic.
It has to be. And this assessment informs a personalized care plan. The hospital then needs to provide the right support labs, imaging, whatever's needed with competent staff, and ensure care is coordinated between different doctors or departments.
And within that care patients chapter, COP, what specific areas do they cover? Emergency rooms.
Definitely. Making sure the ER is ready, right equipment, good communication, protocols to start treatment fast. Also, how to handle care during big community emergencies or disasters.
Important.
Very. Plus standards for safe clinical procedures, blood transfusions, intensive care, maternity and pediatric care, sedation, anesthesia. It's pretty comprehensive.
And medication management, MOM. Always a high-risk area.
Hugely important. The MOM standards demand clear, written guidance for everything pharmacy-related, overseen by a multidisciplinary committee.
Okay.
Safe prescribing is key checking allergies, following minimum requirements for what needs to be on a prescription, and then safe administration, the classic 5 rights. Right patient, right drug, right dose, right route, right time. Verified every time.
Crucial checks. What about the patient side? Rights and education, PRE.
Absolutely fundamental. The PRE chapter mandates clearly defined patient rights and responsibilities. Informed consent is a huge piece of this.
Making sure people understand what they're agreeing to.
Exactly. The procedure, the risks, benefits, alternatives, who's doing it, all in plain language. It also covers what happens if a patient can't make their own decisions. And hospitals need clear ways for patients to give feedback or make complaints.
Good. And infection prevention, IPC, critical everywhere.
Totally. IPC standards focus on having the resources for a strong program, actively working to prevent infections in both patients and staff, managing antibiotic use wisely, antimicrobial stewardship, and tracking infections through surveillance.
Yeah, this NABH framework is incredibly detailed. It gives a much deeper understanding than just saying quality standards.
It really does. It shows the nuts and bolts of how a national system tries to build quality and safety into the healthcare fabric.
Okay, great. Now let's shift gears again. How do we actually know if all this is working? How do we measure quality? Our NCBI sort of talked about this too.
It did. It highlights 2 main reasons, really, for measuring quality. First is quality assurance or accountability.
Like judging performance, making sure standards are met.
Exactly. And because these judgments can have real consequences affecting accreditation, funding, public perception, the measurement needs to be really accurate, statistically sound. You need to be sure differences are real, not just random chance.
Okay, that's one reason. What's the other?
Quality improvement. Here, the goal isn't judgment, it's learning. Identifying where things can be done better.
Or finding who's doing really well.
Yes, maybe finding the positive deviants, the ones getting great results so others can learn from them. Perhaps linking it to incentives to spread best practices.
The outline mentions structure, process, and outcome indicators. Can you break those down?
Sure. Structure indicators are about the setting of care. Staffing levels like nurse-to-patient ratios, equipment, facility conditions, staff qualifications, the resources available.
Okay. Process.
Process indicators look at what is actually done during care. Are doctors following evidence-based guidelines? Are preventative screenings being offered? The actions taken?
And outcome.
Outcome indicators measure the results of care. Things like hospital readmission rates, infection rates, mortality rates, patient-reported outcomes, the end results for the patient.
It sounds like you probably need all 3 to get a full picture, right?
You absolutely do.
Sure.
Relying on just one can be misleading. That's why there's a move towards composite indicators combining several measures into one score.
To give a more rounded view.
Exactly. For
Really?
patients, managers, policymakers. But the article stresses these composites need to be built transparently. You need to know what's gone into the mix.
Right. So where does the data for all this measurement come from?
Several places, each with pros and cons. Administrative data like billing records is often readily available, but wasn't really designed for quality measurement, so it can be limited.
Okay.
Disease-specific registries for cancer, heart disease, etc. can be very rich for specific conditions. Patient satisfaction surveys give the patient's perspective.
But those can be tricky to compare, maybe, across different places.
Very tricky. Expectations vary hugely. And then there's direct observation of care. Very detailed, but costly and time-consuming.
So different tools for different jobs. I also saw a note about risk adjustment. What's that about?
Risk adjustment. That's mainly for outcome measures. It tries to level the playing field statistically.
So?
Well, some hospitals treat sicker patients than others, right? So their raw outcome data might look worse, even if their quality of care is good. Risk adjustment tries to account for those differences in patient health status when making comparisons.
To make comparisons fair.
That's the goal. But the article mentions there's debate about the methods. Some argue that comparing outcome data across hospitals to judge quality is still problematic, even with risk adjustment.
Interesting caveat. Okay, so we've measured quality.
Mm-hmm.
Now, how do we actually improve it? This brings us to quality improvement, or QI.
Exactly. And the Quality Improvement Guide we looked at lays out a really proven methodology for this. QI isn't just hoping things get better, it's a systematic process.
What are the core ideas?
It's usually team-based work, focused on a specific measurable aim. You use frequent measurement to see if changes are actually helping, and you make changes using rapid cycles of testing.
The PDSA cycle. Plan, do, study, act.
That's the one. It's fundamental. You plan a change, you try it out, do it, usually on a small scale, you study the results, what happened, and then you act based on what you learned. Adopt, adapt, or abandon the change.
And you might do lots of these cycles.
Yes, often building on each other, sometimes called PDSA ramps, testing and refining as you go before rolling a change out more widely.
The outline also mentioned tools like process mapping.
Right. Process mapping or flowcharts are super helpful. They visually lay out all the steps in a process, say, admitting a patient.
So you can see where the bottlenecks or problems are.
Precisely. You can do high-level maps or really detailed ones. Other tools include check sheets, simple ways to collect data consistently, and Pareto charts.
Pareto charts.
They help you focus your efforts. They show which problems are causing the most issues, the vital few versus the trivial many, based on frequency. Helps prioritize.
Right.
And measurement plans help teams track progress using things like run charts or control charts to see if changes are leading to real improvement over time, distinguishing normal variation from significant shifts.
And the guide mentioned change concepts. What does that mean?
Change concepts are like general ideas or principles that often lead to improvement. The Institute for Healthcare Improvement, IHI, has a well-known list.
Examples.
Things like simplifying processes, reducing handoffs, improving communication, standardizing procedures, or mistake-proofing.
Mistake-proofing.
Yeah, designing things so errors are hard or impossible to make. Think forcing functions like a plug that only fits one way or checklists and reminders built into the workflow.
So QI is really about a structured, data-driven way to make things better.
Exactly. Constantly asking, what are we trying to accomplish? How will we know a change is an improvement? And what changes can we test that might lead to improvement?
Okay, let's shift to the more formal side. Again, policies and standard operating procedures, SOPs.
Right. Policies, as the vComply source described them, are the written guidelines. They tell staff how to act, how to make decisions. They're crucial for consistency, safety, effectiveness.
And for compliance too, right? Like legal stuff.
Absolutely. Things like HIPAA for privacy, OSHA for safety policies help ensure the organization meets those requirements.
And SOPs are related, but different.
Yeah, SOPs are much more granular. They're the detailed step-by-step instructions for specific tasks. How to draw blood, how to clean equipment, how to document something.
Essential for standardization and training.
Definitely. The Combo source outlined the whole development process.
Yep.
Planning, drafting, reviewing, getting approval, training people, implementing, monitoring, evaluating.
Sounds like a project in itself.
It often is. Tools like Gantt charts or Kanban boards can help manage that process.
But implementing these things can't always be easy. People resist change.
That's a classic challenge. Resistance, feeling buried in paperwork, maybe not having the time or resources.
Any solutions?
The sources suggest things like making SOPs modular, smaller chunks for specific roles involving staff and development, refining them based on feedback, rolling them out in phases, and using technology where possible to make them accessible and easier to manage.
So clear policies and SOPs are really the operational backbone.
They provide that essential structure for consistent, safe operations day to day.
Now, how do organizations track how they're doing against all these standards and goals? That brings us to metrics.
Right, healthcare quality metrics. These are the specific things organizations measure to track performance and spot areas for improvement. ClearPoint strategy groups them nicely.
Into categories.
Yeah, mainly effectiveness is the care evidence-based and achieving desired results. Efficiency, are we avoiding waste? And timeliness, are patients getting care promptly?
Can you give some examples for each?
Sure. For effectiveness, hospital readmission rates. If lots of patients come back soon after discharge, maybe the initial care wasn't effective enough. or hospital-acquired conditions, HACs, infections, falls, etc., that happen during care.
Oh, efficiency?
Average time taken for surgeries. High variation might signal inefficiency. Average length of stay in the hospital shorter can be more efficient if effectiveness isn't compromised.
And timeliness, wait times.
Exactly. Patient wait times at different stages. Arrival to getting a bed, waiting to see a nurse or doctor, waiting for discharge. Tracking these helps identify bottlenecks.
It sounds like having the right metrics gives you concrete data to work with.
It does. And software like ClearPoint can help track these, visualize trends, and link them back to the organization's overall strategic goals for quality.
Let's quickly touch on clinical governance. Sounds like a high-level concept.
It is sort of the umbrella system. The PMC source defines it as how healthcare organizations ensure they're continuously improving quality and safeguarding standards.
Ensuring care is safe and effective.
Yes, through what they call assured care. That involves using various mechanisms, accreditation like we discussed, but also inspections, audits, performance monitoring, both voluntary and required checks.
And regular meetings to review things.
Right. Regular clinical governance meetings, discussing performance, deciding on changes, and making sure those changes are communicated and implemented.
So it fosters that culture of accountability and continuous improvement from the top down.
Precisely. It's the framework ensuring quality and safety remain constant priorities.
Okay, one last but absolutely crucial piece. Documentation.
Cannot overstate its importance. As the consensus source points out, accurate documentation is vital for so many reasons.
Patient care, obviously.
First and foremost, it's the record of what happened, the patient's status. Good documentation prevents errors, ensures continuity when care is handed over. It's essential for communication within the team.
And other reasons?
Financial health accurate records support billing and prevent insurance denials. And liability good documentation is the best defense against malpractice claims. It shows what was done and why.
But documentation can be a challenge. Lots of notes, unstructured text.
Huge challenge. Trying to find specific information in pages of free text is hard. The source mentions benefits of structured data entry where possible, or using smart tools.
Like AI or NLP.
Yeah, natural language processing tools that can analyze unstructured text and pull out key information, making it more usable for quality measurement or research.
So good documentation isn't just paperwork. It underpins everything else we've talked about.
Absolutely. It's the foundation. Without it, measuring quality, improving processes, ensuring safety, it all becomes much, much harder.
Well, this has really been quite the journey through the world of healthcare quality and safety. It's clearly, incredibly complex.
It really is multifaceted. You've got international standards, national bodies, specific guidelines, accreditation rules, and then this whole culture and methodology of continuous improvement.
Driven by data, by well-designed processes.
And it's never done, is it? Ensuring quality and safety is an ongoing process. Setting standards, measuring how you're doing, implementing best practices, trying to build that culture of safety.
And constant improvement.
Yeah, a relentless pursuit, really.
So as you listening, reflect on all these different layers. We've covered the big standards, the guidelines, the measurements, the improvement cycles, the paperwork. What single area do you think holds the most potential right now for really pushing patient outcomes and experiences forward?
It's a tough question. They're all so interconnected.
They are. It really makes you think about how all these systems work together and, maybe most importantly, the human element right at the center of delivering that care.